Hello, and welcome to the 58th Bi-Monthly Breastfeeding Coalition's webinar. I am Amelia Pasmaiz, Deputy Director of USBC, and this series is jointly hosted by CDC's Division of Nutrition, Physical Activity, and Obesity, and by the USBC. The webinars, referred to as the 222, are held on the second Tuesdays of even-numbered months from 2 to 3 p.m. Eastern Time. The purpose of this series is to bring together breastfeeding coalitions to share best practices and news, and to network and collaborate on issues of national significance. Coalition members and breastfeeding advocates from around the country can join us for these free webinars. Join the Coalition's Learning Connection to get all of our announcements. Topic and speaker details are posted 1 to 2 weeks before each session on the page of the USBC public website. And session details are also posted in the Coalition's Learning Connection, for which a user account is required. To streamline access, these webinars have now been set up as a series. You only need to register for the series once, and then you will receive reminders before each webinar with the topic and speaker details. Even though you may not have been able to attend every session live, the series registration will still send you auto reminders so that you have easy updates on the topic and links to the live webinar as well as the archives. The webinar presentation, handouts, and video recordings of this and past sessions can be found in the Coalition's webinar page. You will have that information on your webinar confirmation email. You can find the archives of these as well as updates for ongoing coalitions. If you navigate to the Coalitions section of the toolbar and then select the CDC-USBC bi-monthly webinars. For today's session, all participants are in listen-only mode. We will set 10 to 15 minutes for questions and answers at the end of the presentation. You can type your questions at any time during the webinar. And here's how you do it. Go to the control panel on the right of your screen. If you don't see it, it may be minimized. Click on the orange tab and it will pop back out. If you scroll down below the audio section, you'll see a tab for questions. When you click on it, it will open a box for you to type in. If you have any webinar-related tech problems, please send an email to coalitions@usbreastfeeding.org, and our staff will do their best to help you. And that brings me to today's session, community-based doula programs, innovative program models that support families. The webinar will provide an opportunity for participants to learn about this unique approach to supporting new families, particularly in underserved communities. HealthConnect One is a national organization and a leader in advancing respectful, community-based peer-to-peer support for pregnancy, birth, breastfeeding, and early parenting. Its vision is to see every baby, mother, and family thrive in a healthy community. HealthConnect One received funding from HRSA to provide technical assistance and training to federally funded sites. At today's session, we will get an in-depth look at the community-based doula program, which has been replicated in 40 sites in 15 states, and learn how this model addresses equity in breastfeeding support. There are 3 learning objectives today. The first is to understand the impact of the 5 essential components of HealthConnect One's community-based doula model. The second is to feel excited about learning how this model impacts breastfeeding outcomes. And the third is to know how HealthConnect One's community-based doula model addresses equity in underserved communities. And so I'm delighted to introduce today's presenters. Brenda Reyes is the program manager at HealthConnect One. She is a well-respected and knowledgeable breastfeeding advocate. Brenda conducts breastfeeding peer counselor trainings for frontline staff at health and social service agencies, presents workshops for WIC and MCH case management staff, and collaborates with a variety of partner agencies to provide effective and engaging peer counseling services for breastfeeding women in Chicago. Ms. Reyes manages partner relationships creates tools for reporting and evaluation, and works with the HealthConnect program team to develop goals and monitor progress. Next, I want to introduce Tikvah Wadley. She is the project coordinator at HealthConnect One and is a certified doula and birth doula trainer through DONA. Tikvah Wadley has worked in the community for nearly 20 years and believes in empowering women in today's society. Her didactic and experiential training approach welcomes creativity and learning for every participant. An activist for women's health, she has served as a lactation counselor since 2003 and a certified childbirth educator since 2002. In 2012, she trained young women to become community-based doulas for youth in Chicago's foster care system through HealthConnect One's partnership with UCAN. She continues working with this program and with other community-based peer-to-peer support programs around the country today. Before joining the HealthConnect One staff, she was instrumental in recruiting more than 500 women for the University of Chicago Doula Project, taught a variety of classes for the YMCA, and co-trained breastfeeding peer counselors and community health workers in collaboration with existing HealthConnect One staff. So welcome, Brenda and Tikvah.
Hi, it's Brenda. Hi, it's Brenda Reyes speaking, and my colleague. This is Tikvah Wadley. So we are very happy to be here and to share a little bit of our experience and what we have learned. So thank you so much for having us here. Can you move the slides, Danae? You can move it. So Amelia already shared a little bit about our mission and our vision. HealthConnect One has been in existence since the late 1980s. So we do provide training and consulting and support to different types of organizations across the country who are interested in doing quality improvement around their maternal child health programs, to either increase support around breastfeeding or increase support around pregnancy and parenting. So we wanted to share a little bit more about our model and the 5 essential components of our model. So I also wanted to share first that these are 5 essential components that we have learned throughout the experience in implementing our work. And the 5 essential components also came not only from implementing the program from our partners around the country, but what we came to consensus on what's going to be impactful and what's going to help us get the type of outcomes that we want collectively. So when we brought our partners together, these are the 5 essential components that we came to consensus to that are important and make a difference in implementing either a community-based doula model or our breastfeeding peer counselor model. So the first essential component that you see on the screen is talking about employing community-based either peer counselors or doulas who are trusted members of the target community. And that statement in itself can be looking at, you know, race, ethnicity, language, culture, similar experiences, being from the same target community that's going to be served. And the key word that you're going to see is trusted. So this has to be a member that is trusted from the community, that is respected, that is valued, that is a natural leader in her community. So it's very important. This is a component that is essential for success. That our partners have identified that it's really important for the program, you know, in order for the program to be successful. So the second component is our model really looks at extending and intensifying the role of that community-based doula, which the community-based doula works with families in early pregnancy through the first months postpartum. The peer counselor's role is also very important to connect with families and women prenatally and counsel them so that she's able to provide that support in early postpartum and throughout her breastfeeding experience. So this is really important because, again, if you noticed that the engagement happens prenatally, so it's not being a doula and just being called on at the last minute to attend a birth, or working, the peer counselors are not reaching moms just in the postpartum period. So it's really encouraging the important role of connecting with families at the community during the pregnancy, which is essential. And the reason why it's essential is because we need to be able to establish trust with the families that we're serving and be able to identify what are their needs during pregnancy and how we can support them to meet their goals. You could go on.
That would be me next. This is Tikvah Wadley. We also, part of the 5 essential components, we collaborate with community stakeholders and institutions and use a diverse team approach. Pretty much what we do is everyone that we work with, if they want to have a community-based doula program or a breastfeeding program, peer counsel program, we have a stakeholders meeting. This is necessary. We will not put the program in place if there's no stakeholders meeting. Usually for stakeholders meeting, we invite WIC people, we invite the doctors, we invite hospitals, we invite patients, clients, we even invite aldermen, we invite everyone who has a stake involved. That way we want to make sure that before we put the program in place, there's a buy-in. And if there's a buy-in and everyone knows that they're responsible for the program, not just that agency that's having a program, but everyone has a stake involved, it's a better sustainability approach. We also use diverse team approach because, again, when you're doing these type of trainings, they want to look down and see themselves. They want to know some type of way, where can they relate with you or you can relate with them, that they'll be able to really receive from you and hear and be able to take on the new role as a breastfeeding peer counselor or a community-based doula. We found that when you do the diverse team approach, it really is successful versus us coming in and telling them what it is they need to do. But if they have someone, again, that looks like them, they are much more apt to really hear and take on the role. So you can change the next slide, please, Danae. We found doing these trainings, this kind of is a little unusual for traditional training and education. We use to facilitate, this is one of our essential components, we facilitate experiential learning using popular education techniques and the HealthConnect One training curriculum. We have a curriculum that is comprised of, we have doulas, we have midwives, we have people who have done the work and come together and there's a curriculum made. But the popular education technique is really what we use because everyone has an experience. So if they had an experience concerning a loss of a baby, we don't exclude that experience. We want to include that experience, and that way that they'll be able to hear and also know that their experience is counted for the work that they're going to be doing. So when you look at experiential learning, and I know a lot of times people say, oh, that doesn't count. According to this stat or according to this research, we found this. So we do the experiential learning as well as respect to the community and respect to the adult who's in the training. So you can change for me, Danae. Thank you. We value community-based doulas and peer counselors with salary and support. Okay, I get all excited. We have a lot of people who want to do good work and they want to do volunteer work. And there's nothing wrong with wanting to do volunteer work. But a lot of these doulas that we use, they don't have money. They don't have, they have families and they are not able to support their family just by coming out doing something nice and good. So we have made this one of our components. You must value them with pay. They're away from their families. They're out supporting another family, and it's only right to support and give them salary and support. Another thing we do is we value them with supervision. Reflective supervision is used every week for this doula or peer counselor to be able to come, talk to their supervisor and let the supervisor hear what they're going through, and they come up with solutions. We also make sure that they're valued if they need to take off. They have, sick days. If they need to take vacations, they have benefits. If they're sick, they have benefits. And this way, too, they're supported. So when you think about the 5 essential components, this really is what make up the programs, and this is why they have the fidelity to the model if they have these if they have these essential components in place. So, She knows to move around. She's good. So in terms of the programs, the community-based doula program, again, provides this ongoing continuum of support. It's really a program that is based on relationships, building trusting relationships with families, with communities, with partners. It's really based on the peer-to-peer support model during pregnancy, labor, birth, and the postpartum period. The same is true for our breastfeeding peer counselor program, is being able to provide that continuous support, which is also based on building trusting relationships throughout breastfeeding so that women can achieve their breastfeeding goals that they have set for themselves. A lot of the programs that are partners, the communities that they serve, are either low-income communities, economically challenged communities, and they're also underserved communities. This program is based really on a community health worker model, and for our community-based doula program, it's also a home visiting intensive model. So now that we've shared a little bit about our 5 essential components, we're going to share our study and the data that we looked at and what we learned from doing the data analysis. You can go to our website, www.healthconnect1.org, to download the Perinatal Revolution. So the study that was conducted, we invited an expert panel to do and look at the data and also provide recommendations for sustainability for the future. Part of that data analysis was 4 years of implementing the community-based doula program and looking and studying those outcomes. Okay. We had, the HRSA had funded 6 sites, and that were, they funded 6 sites, but for this particular study, we had invited which was MHP Salute, Family First, the Birth Circle in Pennsylvania, Pittsburgh. We had Birth Matters, Brooklyn Young Mothers Collective, Great Lakes Intertribal Council. We had Healthy Families Initiative and Mothering Mothers in New Jersey. We had, you can go ahead. So what they recruited was they had 592 women. All were first-time moms. 47% of them was Hispanic, 33% was Black or African American. The majority of age was between 18 to 24 years old. We had 65.6% completed some high school or had a GED. 86.6% were eligible for WIC, economically disadvantaged. We had 42.38% experience a medical condition, heart disease, diabetes, asthma, etc. Many mothers were experiencing challenges of economic, family, physical, and mental health.
So in terms of when the analysis of the data was done with the expert panel, one of the things that they looked at for the program was breastfeeding outcomes. So if you can look at this slide, in terms of moms and families that identified either as Hispanic or Latina, they have an initiation rate, and this is just breastfeeding duration, not looking at exclusivity, of 96.35%. And the comparison data that the expert panel used for comparing our outcomes was we looked at PRAMS data, Pregnancy Risk Assessment Management System. We looked at that data and did a comparison. And you can see the community-based doula program outcomes of breastfeeding on the top with the purple line, and then the PRAMS data with the orange line. So you could definitely see that we start off around the same, right? But when we start looking at duration, in terms of Hispanic families, we're already reaching Healthy People 2020 national goals. So it's you could see the big gap in difference in 6 weeks. So again, what that is telling me is about the importance of the continuous support and the impact of that continuous support. So you can move to the next slide, Danae. So the same thing for breastfeeding exclusivity, right? We start off pretty much the same between PRAMS and then our community-based doula model, but you see that at 6 weeks, there's a big difference of 90% versus 61.11%. And at 3 months, you have 78.82. So it's really a tremendous difference. Now, I want you to keep in mind what the characteristics of the communities and the families are that we're working with. It is amazing to be able to see the beautiful outcomes that our families are able to achieve, given the barriers that they encounter, right? That they are not delivering at baby-friendly hospitals. They're dealing with implicit bias and institutional racism, that they are dealing with economic issues, with other health conditions, that they are still, able to get these beautiful outcomes is quite amazing. Go on. So the same thing is for our Black and African American families. You start off around the same, right? 76.83%. And then again, you see this wide gap, and you see how at 6 weeks, you still have 74.49 under the community-based doula model breastfeeding. And there's a decrease at 3 months, 56.94. And then at 6 months, we were at 37.14. But again, nevertheless, you see the big difference, right, and the type of support that makes the difference for our Black and African American families. And again, the same goes for our communities, the situations and the things that our communities are dealing with, and yet we're able to celebrate wonderful outcomes for our Black and African American communities too. So in terms of exclusive breastfeeding, again, you could see the big difference. I'm not going to go and say every percentage, but you see the widest gap at 6 months. You look at, with the community-based doula model, we have outcomes of 39.13 versus 7.39. That is a very, very big gap. And when we're talking about impacting health, when we're looking at equity, I think that this is a promising model, right, in terms of decreasing that gap.
A lot of times when you hear about different studies, we very rarely hear about the tribal community. So we included that with this study. It's a small but important number of American Indian participants were served by community-based doulas in this cohort. The community-based doula site was at Great Lakes Intertribal Council, which served 4 different tribal communities, experiencing a number of positive health outcomes, including high breastfeeding rates and low C-section rates. The numbers for breastfeeding initiation is 83.9%. Breastfeeding rate at 6 months was 28.6%. And we celebrate that their initiation rate was 83.9%. Okay, go to my next one. So this right here, the community-based doula, and the participants, as far as it go, with 25% C-section rate versus PRAMs, which was at 30%, it makes a huge difference to have peer counselors and community-based doulas, more so while they're pregnant. Because again, it's relationship-based model, and when they're building that relationship, they're building also trust, as well as the doula is doing home visits and breastfeeding peer counselor doing home visits, and they're talking to them about different techniques of having your baby, different medications that are out that they use during having the baby, position changes, they can use during having their baby. But all the time it's building a relationship, as well as building up the mother and the family to show her your body is made for this. Your body is made to feed your baby. Your body is made to go through labor and delivery and have an awesome birth. It's made for that. So right here we have 24% versus PRAMs, and these are reasons why we have these numbers. Thank you. Go to the next. So the skin to skin is huge among our participants as well as our doula sites. We have now so many. We have 73%, which is huge. Not to hear first, you didn't hear about skin to skin. They didn't. When we were trained, they would say, "What's that?" We don't understand what's that. Now you see the numbers that they know what that is. 73%. We love these numbers, and we're excited to speak about them. Thank you.
So in terms of the data analysis and looking at the breastfeeding outcomes and what impacted those outcomes, and doing the analysis, what they found for the community-based doula program, that in order to obtain those outcomes, the community-based doula needed to attend the birth. She needed to be present at the birth. Another thing that impacted those outcomes was that community-based doula needed to be present longer than 2 hours after the delivery, after the birth of the baby. So it isn't just showing up for the birth, but staying 2 hours after the birth. Not saying, "Ciao, your baby was born, see you later." The other thing that we keep sharing, that my colleague and I, and you probably hear us talk about consistently, is that prenatal engagement, that support. When they looked at what impacted breastfeeding outcomes, they also noticed that those who had had 6 or more prenatal visits with their community-based doula were tended to have better breastfeeding outcomes, initiation and duration. So it's not only attending the birth, it's not only staying there 2 hours and more after the birth, but it's that prenatal engagement that makes the difference for our communities, and building the confidence of that mama, that family, so that she can reach her goals. So that prenatal visit is essential. It's really important. So again, we invite you to follow us on Facebook, follow us on Twitter, follow our blog. In our blog, we feature a lot of our partners and also the family stakeholders around issues around birth, breastfeeding, and parenting, and we also have a LinkedIn account. So we're happy, my colleague and I are very happy to take any questions, comments, to share.
Thank you, ladies, for that presentation. We do have a couple of questions. The first question was, what kind of funding do you have to support the salary and benefits for the workers? Can you speak more about if you have a partnership with someone that's helping to fund that?
So excellent question. That's a question that doesn't fail to be asked at every presentation in terms of funding. I think it's going to vary by state, to be quite honest. There are some programs that rely or have used Head Start, early Head Start funding, home visiting program funding through Healthy Start to implement these type of programs. There are some institutions that have relied, again, on private funding and also foundation funding. There are some hospitals I'm seeing more that are even taking, investing, right, as part of their budget to include a position like this. And there's more exploration on that. So it has to be both public, private funding that comes together for that. But our programs have either used home visiting or early Head Start funding for that, and foundation funding. Great question.
Great, thank you. Another question is, do mothers have to pay for the services that are provided, or is it reimbursable through insurance?
Well, usually this model, moms and families do not pay for this. That's when you have the organization that actually put the doula program in that community. They have funding already to pay, to make sure that they cover the doula's salary as well as her time and time out with the family. So that's when we were talking in the beginning about the stakeholders meeting. Before we get to the stakeholders meeting, usually when they approach us, they have funding before we come. So sometimes it's set up like that with their private funding and sometimes fundraising, as well as when stakeholders come, you even have some hospitals want to do buy-in as well, but usually families do not pay because, again, they're the underserved community, so we don't charge them. It's pretty much the doula salary is already paid for and breastfeeding and peer counselor salary is covered.
Great.
Thank you for that question.
Yeah. Can you speak more about how you recruit women to work for the program, and then also just go over the states that have this program again?
That's good. Usually when we recruit, now are they asking for recruiting for the client or for the doula?
For the doula.
Oh, great. Okay. So, so if we, when an organization approach us, they come and say, let's use smoking, for example. They'll say, we have a problem with smoking and we want to have the doulas to help us solve this problem. So we ask them, what is their target community? What neighborhood are they looking to help with this problem? So right then, when they tell us the community, we then ask them, who's the leaders over there? We look at churches, we look at the alderman office, we look at WIC, we look among people as well, and believe it or not, a lot of people will recommend who they believe should be in that program, and it's usually, we have a nice amount of people that way.
I would also say that a lot of our sites, either, like, do you want to talk about UCAN and how they did their engagement?
Yeah, we trained the foster care system, and one of them we needed to have, because again, we want to make sure that the diverse approach, that they look like who they're training, and again, the trainees want to make sure they look out and see themselves. One of the requirements was you need to be a ward of the state. You came out of before you can even go into helping these women. So what they did was they looked through and found ward of states and people who graduated, and they all came, and I was on site for the interview, and there was so many people who came through, but yet it was them who figured out who they wanted to be in the class.
Interesting. Can you talk more about the implications for replication of this program in populations where there are low breastfeeding practices, and what the next steps would be to replicate this program?
That's a really good question.
That's an excellent question. We get so many calls about inquiries regarding replication. Mm-hmm. One of the things as part of implementing the program that we highly recommend to organizations that are looking at developing or implementing this model is that, again, the solution needs to come from the community themselves, and they need to be involved in their own community assessment and identifying what the issues and the problems are, and looking whether this model is a good fit for their community, right? Just because we think it's a great model, it's an excellent model, it might not be a good fit for a particular community. So that's why it's really important that the community is involved in conducting a community-based assessment. It is something that we encouraged our partners to do, to sit down with community members and families themselves to figure out what are their priority issues. Every time I get an inquiry, we encourage organizations to fill out a replication application that is they can download from our website, and it helps us to be able to assess whether this organization is ready, right, for replicating a model like this. Also looking at the culture of our, that organization. If they don't value community knowledge, if they don't value community health workers, well, I don't know if this program is the right program for your organization, because maybe you believe that you need a bachelor degree to be able to serve the community. Do you know what I'm saying? So we have to study each other. The organization studies us and looks at us, and we look at them. So the replication application lets us know, have you done your community assessment? How do you involve the community? How do you feel about the community that you serve? So I think it's a great start for both organizations to have a conversation, but also to assess each other.
And I would like to add something onto that. We've had and this is a good example, even though it's funny. We had an organization approach us and said, you know, they believe that the doula program will be great here. And we said, okay. And this is one of the things we learned, why you need a community needs assessment as well as stakeholders. Well, when we go over to do the program and invite, you know, the community out, they didn't want to know about how you can do immunization. They wanted to know, how could you get that light fixed on their street? They wanted to make sure, you know, that their families was taken care of that way. Is it safe for them to ride up and down the street? Even though the program is great to have there and reduce the rate, you know, infant mortality, they wasn't concerned with that. They were concerned about, how can you help us with our street lights? So that's why we need the community assessment needs to be done. That's what we found that works.
Right. And do you have a model for the community-based assessment? Does HealthConnect One have one?
So we have provided our partner sites. I mean, the replication application itself is a form of assessment, right? So it's helpful for the organizations to fill it out and help them see, you know, what currently data, quantitative and qualitative they have. But our evaluation manager has also developed, not per se like a form, but things that organizations need to consider when implementing a community-based doula, you know, or just an assessment, a community assessment. So we are happy to share that tool with people.
That would be great. Can you speak on some of the challenges you had with implementing the program, and how they were overcome, or how they helped you assess the process?
Mm-hmm. Well, I can use the one a fresh one we use. We were doing the foster care system. So the organization said, okay, we want, because we asked them, we say, we need to make sure that they are wards of the state. And they said, well, okay, we have wards of the state. They said, well, you know what? Some women came through, they will be good grandmas for the moms, you know, for the babies and the women to go. So they were direct entry midwives, and they had invited them for the training. And I said to them, I don't think this is a good idea. And I said, especially if they have not been warded the state. If you want to make sure, we got to make sure we stay in that same lane to help with this problem that you have. Well, they included them. And when they included them, they came in with a lot of foreign jargon that they didn't need to know about. For example, one said she was in Israel and she had trees bowing down. It was really way off. But she kept taking over in the room and not allowing the other women to speak. Now, a lot of these women already have their voices suppressed. They're not really able to speak. So in these trainings, we also help them find their voice, be able to be strong and speak up for themselves. Well, these two midwives had just totally taken over. And I told them, I said, it's not going to work. So we ended up, when we put them out of the training, we can really identify who the true women were, who their voice is really strong. We find out what their thoughts are about labor and delivery, what their labor and delivery was like, who they see themselves being in the future. Can they do this work? All of that was smothered when we had these two women in a room. They have power dynamics that was over the other young women.
Does the program experience a lot of turnover, or how do you retain these doulas, since they're such, integral parts of the community? How do you retain these women?
So I think it goes back to our component number 5, that we have to value women with support, supervision, not supervision, but Tikvah talked about reflective supervision, and maybe she can expand a little bit more on that, and benefits. And I think it's really important, right? The caseload management, the type of support that the peer, either the peer counselor or the community-based doula, what type of support she has available. So I think that, you know, we have to provide community health workers, peer counselors, and doulas with an opportunity to earn a living wage in this country, because that's what's just, that's what's right. They bring a lot of expertise, and they are able to provide a service and connect with families in a way that a lot of us maybe will not be able to connect with families. So maybe, Tikvah, you could talk a lot about, you know, reflective supervision, and that's why that's so essential in retaining. You're a doula yourself, so.
Yeah. So another I would like to add on what Brenda was saying was usually sometime, and that's an excellent question. A lot of times when doulas are, community-based doulas are in this role, they are required to have at least 12 to 15 clients for the year. A lot of our sites are looking at 50 births a year, so sometimes they may have 2 births a month that can get them to that number. And doing this work, 2 births, it can be a lot, especially if you've had some challenging birth outcomes. Or if they've been out, if you in labor and delivery sometimes for like 32 hours and you don't go home. So a lot of times the doulas can experience burnout. Usually when this happens, the supervisor should be able to look at this and see, okay, we need to do something. We need to take her and take care of her, tell her to take care of herself. You know, sometimes when she has these births, don't come in the next day. You know, sit down and, you know, and the supervisor is constantly on the phone too with them, by the way. They're doing these births. They're constantly in contact with them and talking about what's going on with this birth. So they're home and the supervisor is not anything taken away from them. They're not charged with, you know, not coming to work or abandoning a job, none of that. They get an opportunity to go home and rest. Now, the next day, they want to debrief, they want to talk more about this birth, but they also make sure that they go and see the mom. So when we look at these doulas, that they can be burned out, they can if they're not supported properly. So that's one of the things we make sure. That's why we talk about the reflective supervision and the support. Usually when they're doing reflective supervision, they have the opportunity to go and talk about what they've seen, what they've heard with their supervisor. And again, as I was saying earlier, to make sure that they come up with a solution. A lot of times it's not the supervisor telling the doula or breastfeeding peer counselor what they should do. It is the breastfeeding peer counselor and the doula speaking out what their thoughts are about this, what they've seen, and it's trusted from the supervisor's standpoint. Now, it can't be anything whacked and crazy, but definitely this is supported by the supervisor. And sometimes we have some of our sites who do spa days with their doulas. They tend to get their, sometimes get their feet done, and sometimes they may get a massage, but not a full body massage. They've given them partial massage. But they make sure they have arts and crafts. They do belly casting with them. They sit down. They just have lunch and talk about their clients. So they try to do these things to make sure that they're constantly building them and making sure that they don't burn out.
Very nice. Thank you so much. This is Amelia. I really appreciate what you're describing in that, in answering that last question about all the circles of care, that you have this body of women who are serving women, but they're employed in a context where support and guidance is also provided to them. So I love that image. So thank you everyone for submitting so many great questions so we could have a really robust dialogue with these wonderful presenters. Before we go today, I want to turn it over to CDC to provide some updates. So we have Catherine Sheely and Reyes Grossner-Klaus from DNPAO to share CDC News and Updates with us.
This is Kat. Can you hear me?
Yes, we can. Thank you.
Oh, yay. Okay. So I believe that Doris is unable to actually speak.
Kat, can you hear me? Catherine?
Oh, yay. She figured it out. Okay. Doris, you go ahead first.
Okay. Thanks, Catherine and Amelia. It was a very interesting presentation, and good afternoon, everybody. I wanted to just give you a brief update on a couple of the activities that I'm involved with. First, the Empower Breastfeeding Initiative. This is our CDC-funded quality improvement program designed to help the 94 participating hospitals achieve baby-friendly designation. We're about midway through the second year of funding and also about midway through the project period. The hospital teams have been actively engaged. They receive highly individualized technical assistance from breastfeeding and quality improvement coaches. This has been ongoing and will continue through the rest of the project. And they also have had the opportunity to share and learn from each other during state-based cohort calls where all the hospitals in the state get together and discuss issues, as well as all hospital webinars and other kinds of opportunities. The hospital teams did take part in a face-to-face learning collaborative meetings. There were 2 of them held in May, one in Atlanta and one in Baltimore. So 88 of the hospitals attended those. They were very well received. The hospitals were very actively engaged in both formal and informal opportunities to learn from one another. The hospitals are making steady progress. More than half of the hospitals are in D2 and D3 of the 4D pathway. I think if you would like to learn more about the initiative, I would encourage you to visit the Empower Breastfeeding website, and it's just at empowerbreastfeeding.org, all lowercase. The website does feature a newsroom, and it spotlights some of the participating hospitals. I think that you might find that interesting to see if any of your local hospitals are included in the spotlight. And you can also follow the initiative on Facebook and Twitter. In terms of our MPINC survey, as you all are aware, the 2015 data collection is closed, and the data are currently being analyzed at CDC. And we expect that we will start to send out the reports, the benchmark reports first, beginning in the fall, and then those will be followed by the state reports later in the fall. So, Catherine, I think it's time for you to give an update on the Baby Friendly Hospital Initiative. Thank you.
Yay, technology. Well, one of the most exciting things, I think, from the USBC and the region standpoint is that we now have all USBC regions have more than the Healthy People 2020 objective of births at baby-friendly hospitals. So that is pretty darn cool. Also, 2 regions, the West and the Northeast, have more than 20% of babies now born at baby-friendly hospitals. So that is very exciting, but the current, as of, the latest and greatest, so I know some of you know that we keep track on a rather microscopic basis of how many babies are born at baby-friendly hospitals, and we are now at 17.7% of babies in the U.S. are now born at baby-friendly hospitals, and that is at 353 hospitals. So we all need to do a giant cheer and emotional support for West Virginia so that we can then have one in every state. So that's all for today. Thank you very much. Amelia, back to you.
Thank you, CDC friends. And so then I also want to share with all of you, as you may be aware, Kelly Scanlon stepped in to fill the role that was vacated by Larry Grummerstrong when he moved on to the World Health Organization. And now I am sad to announce that Kelly Scanlon is moving on to USDA. I believe she's wrapping up this week or very, very soon. And while we look forward to continuing to get to work with Kelly in her new position, we're very sad to see her leave CDC, and we know that our CDC colleagues are, we're happy to not have to say these words out loud. It's a big day, big time of transition for all of them. I next want to share just a few quick USBC updates in our remaining moments. Registration is open for the 2016 National Breastfeeding Coalitions Conference. You can visit the conference web page for all of the details. And we also, let's see, I think that's the next slide, Danae. There we go. So the one that you were looking at was about the Coalition's Learning Connection, my apologies. And now you're seeing information about the open registration for the conference. And then on our next slide, you'll note that we are hosting a Twitter party this Thursday, June 16th. And we invite you to join us for a dialogue between organizations and dads called, using the hashtag #WhatDadsNeed. Our guest host that day is going to be the father who blogs at The Adventures of Captain Dad, and he is also featured in a blog post this week. So we hope you can join us for that Twitter chat. And finally, I want to say thank you. This brings us to the end of today's session, and we appreciate that HealthConnect One was able to teach us more about the 5 essential components of their community-based doula program. That was very inspiring. I particularly liked hearing about their very thoughtful recruiting process. It really helped make it real for me what it is they do when they're engaging with a new community and making sure that the work that emerges there really stays to the heart and intent of their program. And also many thanks to all of you for all that you do to improve the lives of women, children, and families. We hope very much that the 222 webinars bring you ideas for collaborative action. Please complete the webinar evaluation and let us know how we are doing. Your suggestions are valued and help us bring you webinar topics that are relevant to you. You also get a certificate of attendance when you complete the evaluation. Goodbye for now, and I look forward to having you all on for our next webinar.